Good morning, everyone. Delighted to be here. Honored to be part of the third year anniversary and celebration of St. Clair and the Mayo Clinic Care Network. I want to thank Dr. Collins, Dr. Sullivan, Dr. Hayes for inviting me to give this talk. And again, hopefully this can be very interactive. We can go through the talk, or you can interrupt me if you like. And as Dr. Sullivan mentioned, I'm going to be talking about high-value healthcare, both at the macro and at the micro level. So here are my disclosures, no relationship with the industry, some research grants and boards and advisory councils. So the three objectives, or the three learning objectives that we want to leave with here today and topics are really around the gaps in health and healthcare delivery. Number two, as Dr. Sullivan mentioned, the opportunities for standardization and reliability in our healthcare system. And third, and most importantly, ending up with the importance of culture and values and how they're all connected. So what does healthcare look like in 2019 for us? And the current reality is the federal government currently spends about $5 billion to develop, test, and develop policies around penalties and rewards based on over 2,300 quality measures. So as St. Clair Hospital and Mayo Clinic, you are subject to all of this, including collecting that data, submitting the data, getting benchmark performance, and getting the penalty or the reward. But the question here that actually the federal government is asking, this is the Department of Health and Human Services, the VA, Department of Defense, CMS, is have these 2,300 measures and this $5 billion investment led to uneven outcomes in patient outcomes, safety, and experience, and currently how we deliver care? Have they actually improved the health of Americans? And can they improve them when we fully understand the true determinants of health amongst our patients and population are really probably only 10% affected by the care we deliver in hospitals by physicians and nurses. 20% are due to the environment, the city you live in, your home, 30% are genetic, and 40% are due to your individual behaviors. And lastly, the whole issue of affordability and accessibility in healthcare, and how that's actually going to be linked to our entire US economy. What does that mean? So having spent over 2.5 decades in quality, safety, and patient experience, I'm just going to highlight at a very high level what we've learned and really what we desire. So what we've learned is we have disparities in actually access to care and the care we provide when we truly want equity for our population, our consumers. Having done health services research almost my entire career, I can tell you that there's almost nothing we found in the literature that an elderly minority woman gets better or more of than a young white man. And that could be from mammography screening to bypass surgery. And we can keep publishing this information because that's what it's showing us. Number two, we have variation in our care, both at the macro and micro level when we want standardization and reliability. So what do I mean by the macro level? Mayo Clinic has a lot of sites. It's probably not unusual if you went to a hospital in Arizona versus our hospital in Rochester, Minnesota, that you might get different care for the same condition. And how do we standardize that? So if you're exactly alike, you get the same care. At the micro level, if you show up at one of our hospitals, depending on which cardiologist you saw that day or that week, you might get different care. Again, if that's because the patients are different, fantastic. We should provide different care. But if that's due to preferences, then that's something we need to work on. Fragmentation. And the fragmentation is borne out in how patients access the system, how many doctors they see, where they see them, when we truly want coordination. A seminal paper was published from the Medicare database about a decade ago by Dr. Homei Pham, which indicated that in a single year, a Medicare beneficiary in a single year sees 2 primary care physicians, 4 specialists across 5 different practices. So if we're going to implement pay for performance for measuring hypertension, blood pressure control, which one of those physicians should be accountable and should be attributable for measuring and monitoring blood pressure. We have low safety when we're seeking high reliability. We have defects in healthcare routinely. Not all of it reach the patient, but the near misses in healthcare probably are a 2 sigma, 3 sigma, 1 in 10, 1 in 100 occurrence. We have high cost, and when we're seeking to be lowering our costs nationally. Now, place upon this the current environment where trust in healthcare is clearly eroding, right? Trust in each other and the federal government is eroding. I'm not just saying the executive branch, I'm saying the legislative branch. Trust in each other is eroding, but in healthcare, you can see the erosion of trust for doctors and medicine has eroded from about as high as 60% now to about 37%. 37% of Americans trust that doctors, hospitals, healthcare in general will help them solve problems or help deal with the issues of affordability or an Ebola crisis or a new infection. Whereas you can see, at least in the academic world, in the scientific community, that trust seems to have been maintained right around 44%, and that's universities, scientists. So why would we have this issue in trust in healthcare? I mean, what did Dr. Sullivan, Dr. Hayes, or myself do or didn't do? Well, it actually may not be actually us, right? So if you think about the headlines you may have seen, we have a company that literally lied to patients, doctors, and their investors about their product and the results. We have breaches, cybersecurity breaches of data that we are supposed to be protecting. 78.8 million records exposed. We have prominent physicians who are conducting seminal clinical trials to determine the effectiveness of chemotherapy drugs, who at the same time are receiving $1 million consulting fees from those same companies. And lastly, we have, just recently in the news, a pharmaceutical firm offering to settle a law case for $12 billion. It's a lot of money, right, if you're actually not guilty of something. Turning to affordability and accessibility, this is from the Gallup poll from most recently is last year, and you can see that the majority of Americans, close to 80%, seem to be quite dissatisfied with the cost of our healthcare system. So with this next election cycle, I think this economy and terrorism or security, national security, are probably going to be the major issues for us. And affordability and accessibility is rising and not falling at all. Why is that? Well, this is the percent of healthcare spending as a percentage of U.S. gross domestic product and projecting out for the next decade. That would be not sustainable for the U.S. economy. The U.S. economy is already being challenged as the world's largest economy. But there's no other economy in the world that's spending 17, 18, 20% on healthcare. Most other developed countries are spending around 10% or less. So if this trend continues, this will impact the entire U.S. economy, our prices, and consumers. So glad we have some in the audience, some people from universities and healthcare economists. But if you ask a healthcare economist, why does healthcare cost so much in this country? They'll tell you cost is a simple equation of use versus price times price. And by use, we mean the variability in tests, drugs, and treatments that we do in the US. And by price, we're talking about the price of drugs, devices, supply chain, labor, and management. Healthcare costs 3 times or more in the United States than any other country in the world, not because of use. Yes, we might have some overuse and some tests and some drugs and some services, but that's at most 20%, 30%, 40%, 50% than Germany, France, or Britain. But the real issue about cost in the US healthcare system is the prices. It's the prices that our healthcare system pays for those issues, including labor and management. So at Mayo Clinic, we have 3 destination medical centers or sites in Scottsdale, Arizona, Jacksonville, Florida, and Rochester, Minnesota. We also have the Mayo Clinic Health System of community hospitals, and we have the Mayo Clinic Care Network and affiliations. But within our destination sites, we have focused on serious or complex conditions, so where Mayo Clinic offers a unique expertise. Our Mayo Clinic Health System and many of our Mayo Clinic Care Network sites do the same, but they also provide a lot of common care for routine conditions, as well as a simple routine care. So how does that fit within the affordability pyramid when you think about the care pyramid? So we've started addressing this with thinking about value. So how can we disrupt healthcare? So there are other faces of this pyramid, and the type of customer segments we face. There are high-end customers who may view destination medical centers as a luxury good and are not price sensitive. But there are many, many low-end customers who probably cannot afford costs for most care, unlikely to pay for higher quality over convenience. And so for Mayo Clinic to focus on just the top of the pyramid for serious and complex, we need to also focus on the entire pyramid when it comes to customer segments. Because even amongst the high-end customers, when they're over 65 and they're Medicare, they are mainstream customers. They're not paying for their hospital bills or hospital costs. Another way for us to think about this is think about the care delivery segments of how we provide care and how we stay connected to the different customer segments. I forgot to mention, Clayton Christensen, who talks about disruptive innovation, like the smartphones, will contend that most of the innovations and disruptions actually happens at the low-end customer level, not at the high-end. So if we're going to disrupt healthcare, we're going to have to focus on the low-end customers. So care delivery. And I think this is where medicine has the greatest opportunity and challenge, which is really moving towards digital and virtual care for common conditions and platforms for simple and routine conditions. All of us, who are in healthcare are probably lucky because we can sort of text and message or call our colleagues when we have a condition amongst a friend or a loved one when we don't know what it is and we need assurance or need advice to go in. But that's not available to the great majority of Americans. And how do we make that available, that knowledge and information available in a platform setting, and have value in that care exchange? Platforms like Amazon, Uber, Apple iPhones. If you just think about what platforms exist in healthcare right now, not aware of actually any. We have platforms internally, but not one where the entire healthcare ecosystem comes and joins. Just at dinner last night, at our table, I asked the question, how many of you are not on Amazon Prime? Now that question 10 years ago got a different response. Literally at our dinner table is one person who was not on Amazon Prime. He has access through his family though. I think it's called sharing a username. So at Mayo Clinic, the work we've done for the last 5 years is really what we call our Practice Optimization Acceleration Projects, the POA projects, which is really trying to make healthcare more efficient without losing the quality, safety, and experience. So trying to cut out clinical waste, administrative waste, applying industrial methods like Lean and Six Sigma, change management to our care processes and care models and driving out that waste. And most of that work has focused on disease states, which is like how do we do hip replacements, how do we do bypass surgery, and trying to make that as efficient as possible, at least for the 70 or 80% of patients which are identical. And that you can see across our sites in Arizona, Florida, and Rochester, and the cost savings we've achieved over time, which is fantastic. It's made us more efficient. It's a lot more to go. But this is probably not going to be sufficient in terms of affordability for us. So we're pivoting to mapping people, process, and flow, eliminating unnecessary work and variability, and transforming that to what we're going to call digital practice optimization acceleration. So what does that mean? That actually means analyzing a clinical data platform with AI, machine learning, and natural language processing. So Mayo Clinic last year went to Epic as a single instance across all of our sites. So literally 20 hospitals all went on Epic. And we are actually the only healthcare organization I'm aware of that uploaded 10 years of historic data. And the reason we did that was to develop a clinical data platform so we can analyze it and determine what is best practice and best performance, and to inform clinicians real time at the point of care about those opportunities and enhance our outcomes, experience, and costs over time. So that may be sort of diffuse and motherhood and apple pie to you, but let me give you a real world example. Literally on a flight last week, I was traveling with one of my most senior GI colleagues. He described to me a case that essentially 80-year-old man who was on anticoagulation with Coumadin for atrial fibrillation, who was having a bowel movement at home, strained. It was at 2 a.m., and there was some blood in the stools. Now, this patient had a normal colonoscopy 6 months ago, but the family was concerned, brought them to the emergency room. The emergency room physician thought the patient should be admitted, although the patient was stable, hemoglobin was stable, vital signs, heart rate and blood pressure was stable. Gets admitted to the medicine hospitalist service. The resident and the nurse practitioner overnight immediately ordered tests, hospitalized the patient, talked to the family, and ordered a colonoscopy for the next day. And my colleague in GI literally met the patient 24 hours later in the endoscopy suite before the procedure. And that's when he put the brakes on. Because he knows that in this kind of situation, either from the GI literature or the hundreds and thousands of patients he's been involved with, the chances they're going to find anything, pathology in this patient, is less than 0.1%. Now the challenge is, how do we get that knowledge and information from a very experienced gastroenterologist to the point of care with the emergency medicine physician and the hospitalist internal medicine physician? We don't do that well, right? Because this patient probably didn't need to be admitted, much less have a colonoscopy. And the result is he put the brakes on, was able to stop everything, but talking to the patient and family and reassuring them and earning their trust again that, hey, we need this procedure, but oh, no, you don't, that's a lot of work. And many of us would have just done the colonoscopy and be done with it. So that's a clear example that we don't know what we know, right? I'm a cardiologist. I've taken care of thousands of heart attack patients in my career, but haven't taken care of millions that Mayo Clinic has. So how do we harness all that digital data, make it information and value, and inform the clinicians at the point of care when we've missed something and missed an opportunity to improve our self-efficacy for the patient right in front of us? So our efforts in affordability at Mayo Clinic, and with full disclosure, Mayo Clinic is certainly not the most affordable or accessible healthcare system. We realize that, and we know that that's got to change, and we're moving towards that. But we're starting to put a framework together of how we're going to focus on affordability and accessibility, and how we're going to pass those cost savings on to payers, employers, and ultimately consumers. And right now, you'll see most of these efforts are really around sort of decreasing our cost base and cost infrastructure. My chief financial officer at Mayo Clinic told me, this is critical work because if we have to jump off the parking lot, I'd rather jump off on the first floor than the 7th floor. And right now, we're looking down on the ground from the 7th floor at Mayo Clinic. So I told you about the digital practice optimization accelerators. We're going to try to do 50 DRGs next year and put the teams together so we can look at 50 DRGs and get to Medicare reimbursement by redesigning care and using digital information. And that has potential impact to look at price as well as variability in use. Remember the cost equation. Making the correct diagnosis and care plan the first time. So often at Mayo Clinic, we see patients after they've had 6 months of multiple tests and multiple procedures, but no diagnosis being made. Virtual encounters replacing physical encounters, probably with decreased unit price, but may not decrease use, so will probably increase use. Geographic distributed models of care, where can care be delivered locally with excellent outcomes and lower costs than coming to Rochester, Minnesota. Providing hospital-level care at home, right? The future hospital of tomorrow probably is just ICU care and intermediate monitoring. Most of the hospital care that we're currently providing probably could be done at home with remote monitoring and systems to keep the patients at home. Developing centers of excellence with employers like Walmart, bundled care, contracts over time taking risk, and most of these alternative payment models that the government is doing. The government has found that despite all these value-based purchasing initiatives, the only thing they've found so far that's actually decreased costs are these bundles for hips and knees and the BPCI, best practice bundles. So at Mayo Clinic, we have a new leadership group in place with a new CEO, Dr. Gianrico Ferrugia. We've gone through a strategic planning exercise and gotten a lot of internal and external input. And we feel that for 2030, in the next decade, these are the major trends in society and our population. It's going to affect healthcare. The whole innovation, cybersecurity, technology disruption. And we feel that disruption is going to come from within. A lot of people feel that it's Amazon and Google who are going to disrupt healthcare. We're of the belief that disruption has to come from within healthcare, for people within healthcare. Consumerism, right? The patient will see you now, right? The old Lucy cartoon that the doctor is in, like 5 cents. Innovation, the social division in our societies, the unaffordability of healthcare, which we've covered, job losses, economic downturn, the anticipated recession in 2020. Our strategies at Mayo Clinic centers around 3 key features: to cure, connect, and transform. A core feature of Mayo Clinic is to cure, right? To discover the new treatments, therapies, diagnosis that allows us to cure. Has a lot of thought about this word. A lot of people want to care. But we put it out there that our hope here is to provide cures for our patients who come to Mayo Clinic. And the only way we're going to do that is connecting with our patients. We're going to have to connect with a lot more patients than those who are physically coming to Mayo Clinic for care in our hospitals and clinics. So how do we connect with them, either through affiliations or through the digital platforms, so that they only need to come for the most serious or complex conditions. But for common care, simple routine care, our knowledge and advice still can be offered. And transforming how we deliver care. Our leadership teams have really challenged us to completely digitize healthcare. We're truly analog today, and to digitize how we care for our patients. My role in quality and affordability can be summed up by currently, those are all the little groups that I have some accountability and oversight for, from outcomes, safety, accreditation, infection, practice redesign, data and applied analytics, health equity, payment programs, our CDI and coding, our external reputation. And we're going to align with our 2030 strategy and within the digital practice, be connected everywhere with them. And that's what we're transforming to, from these shops of expertise, but really to be integrated within all of our practice, the digital practice. So what will healthcare in 2030 look like if we're successful? Well, if I were the patient, I would say, keep me healthy. That's preventive care. Get me better. That's acute care when I need a hospital. Keep me well, right? That's for patients with chronic disease. And treat me with respect for my end-of-life and palliative care. We have to do all 4, not just the acute care component of get me better. That's population health. That's the healthcare ecosystem. And at Mayo Clinic, we're going to do that with real-time actionable data, something we haven't really had to inform our clinicians. We're going to use advanced analytics and digital tools within the practice, and we're going to consider cost not as episodes in the hospital, but costs over time, whether it's 100 days, 6 months, or a year. So, shifting gears, topic 1. Topic 2 is opportunities for standardization. So drilling down a little bit into a couple of specific projects that we've done at Mayo Clinic. Number 1, all of you are aware of the opioid crisis, both in terms of opioid dependence and opioid diversion. Wanted to pull up a historical paper from January of 1980, New England Journal of Medicine. And if I blow it up right here, this author actually said, from Boston University, we conclude that despite widespread use of narcotic drugs in our hospitals, development of addiction is a rare condition in medical patients with no prior history of addiction. We know that this is not true. So in the last couple of years, we embarked on an effort to look at our opioid prescriptions. What's our accountability in the opioid crisis? And we started with our practices in Minnesota, Arizona, and Florida. And if you think about a concept of 200 oral morphine equivalents as what we should be prescribing, sort of as a threshold, which is 25 tablets of oxycodone. That's 200 oral morphine equivalents, 25 tablets. For all of our surgical conditions, from general surgery, surgical oncology, orthopedic, spine, urology, and gynecology, head and neck surgery, what was our baseline prescription rate and use of opioids? So we looked at our data by combining our clinical databases and our prescription data, and this is what we found. So the blue bars represent the interquartile range of oral morphine equivalents. That little orange line shows that 200, the 25 tablets. And you can see for 80% of our procedures, we were prescribing more than 200 oral morphine equivalents or 25 tablets of oxycodone postoperatively on our patients when they go home. That's 80% of our surgeries are receiving what was, by the guidelines, higher doses. Particularly, as you see on the right, for a lot of the orthopedic procedures, which are the highest prescriptions. What was being done with these pills? So when you ask the patients and surveyed them, this is how many opioids they consumed versus how many opioids were left over. So over 50% of the pills we were prescribing were not used. So where were they sitting? Even for the ones of the highest prescription, which is the orthopedic procedures. They were not being used. Opportunities for addiction and drug diversion. So our practice really looked at this and thought long and hard. This is not a good thing, right? This is, we have some accountability in this opioid crisis as a healthcare professional and healthcare system. So our groups of surgeons sat down, talked intensely about this, and came up with this protocol, which guided for all surgeries to start with, except for orthopedics, and recommended low dose, standard dose, high dose for these surgeries. And this was built into our Epic EHR so that physicians no longer had to write their own and prescribe their own. They could just make a click and say, my patient's pretty standard, or my patient should be on the low dose. And we also listed factors on the bottom of who needed more opioids. The factors of people who needed more opioids were people who were on opioids to start with, younger age, non-cancer patients, a heart pain score in the hospital, or a high in-hospital use of opioids. Those are really the only patients that you would even consider the high-dose prescriptions versus low and standard, right? And so that came from within, right? That there wasn't external disruption by, a pharmaceutical company. In implementing this across our surgical practices last year, you can see before in blue and after in orange, the changes in the prescription of opioids within 3 to 6 months of implementation across the house of surgery at Mayo Clinic. And what you'll notice is not only the amount decreased, but the variation decreased. The amount of opioids decreased because people chose a better prescription, and the variability decreased because people were following a standard protocol. Right? So heretofore, we've decreased our opioid prescriptions at Mayo Clinic by over 50%. We then took this to orthopedic surgery, right? The group that was prescribing the highest amount of opioids. And they came up with a slightly modification of different doses for opioids depending on the type of surgery. And same effect for total knee arthroplasties or hip arthroplasties, you can see before and after, shaded and unshaded, both the amount of opioid prescription as well as the variability decreased significantly. I can't believe this is not a good thing. And I can tell you that the adoption by our surgeons has been almost 100% penetration. We built it into the EMR. Another example, hospital-acquired infections. Having overseen a lot of infections in the hospital, I could tell you Clostridium difficile is probably the hardest infection for any hospital to try to improve upon. I'm sure your leaders here will tell you the same. There are things you can do for urinary tract infections, central line associated bloodstream infections, but C. diff is very, very hard because it's in the environment. And this really gets into, hey, how do we break this chain from the infectious agent to the reservoirs, to the vectors, and to our susceptible host? And this chain is complex, and you can't just do one thing. Clostridium difficile is an infection that causes diarrhea in a susceptible host, and there's not a lot of good treatments for it, and often antibiotics will not work, and the treatment for it is a fecal transplant. So think about that. You're taking feces from somebody else to reseed that patient. And the cost of that, a C. diff infection from the hospital, if a patient's in the hospital and gets one, is estimated about $50,000 to $100,000 more for the hospital when you get one of these. The challenge is about 1 in 5 of patients in the community are chronically colonized. When they come to the hospital, it gets colonized within our hospital environment. So these are the things you can do, and these are the things that our sites were doing, working very hard. Yet our performance was sort of average, right? Where how do you clean? How do you do terminal cleaning when the patient leaves with ultraviolet or hydrogen peroxide? How do you clean that shared medical equipment? How do you prevent inappropriate testing, right? The patient who's on laxatives but doesn't actually have diarrhea. Why are we checking the stool? How do we screen for the patients as they come in? Because if they're colonized, do we treat them as if they're infected? Because they'll colonize the room. And the next patient that goes in is probably going to get the infection if they're immunocompromised or on broad spectrum antibiotics. How do we, as a vector, wash our hands and do hand hygiene? Something as simple as hand hygiene and having a code word we each invented called foam, which is if we see somebody not doing hand hygiene, we just say foam. And that's a code word to say, hey, you should be washing your hands. And your response shouldn't be, what are you talking about? I used to think hand hygiene was something my mother told me to do before dinner, but I'll show you some data that is pretty strong that it's more important than doing before dinner. And then the whole issue of antibiotic stewardship and making sure we de-escalate from the broad spectrum antibiotics. So let's talk a little about hand hygiene. So we're doing all these things, but the one thing that tipped us over, despite doing all these things, I think was hand hygiene. So this is data from one of our campuses, Mayo Clinic, Florida. 2018, 2019, August of 2019. We started this initiative in April of 2018, so just a little over a year and a half ago. We started monitoring hand hygiene, not by mystery shoppers, not by random sample of 15, 20, or 30 observations. We wanted to get real data all the time, what was going on with the patient in the room and all the people going in and out of the room. How do we do that? At Mayo Clinic, Florida, which is a pretty new campus, we have security cameras throughout the whole hospital, which of high fidelity can see outside of every room. So we actually asked some of our staff to watch those video cameras and look for hand hygiene and it was done or not. So at baseline, 39% of the time of people entering and exiting the room, they were done, okay? I suspect that at any hospital who looks at this with this kind of data, 3,000 observations per month, this is what you're going to find, unless you've got a major activity going on. That less than half the time that our doctors and nurses and nutritionists and escort and transport people are actually doing hand hygiene as they enter and exit the room. I'm not going to show you the video, but it's pretty telling. We actually have videos and we sort of blur out the faces. You can just see patients going in and out, people going in and out. But you can see what happened, right? We started an initiative and got to 84%. And we're holding at about 84%. The data from the infectious disease literature will suggest that if you do get above 75%, you will have an impact on that chain. and decrease infection rates. So look at when the improvement occurred. It was Q4, right around December, January of 2018. We can actually drill down because we can actually with the images see who it is. Is this a doctor? Is this a nurse? And to our surprise, the group that had the least compliance, even in the most recent data, is environmental services. The people who are in charge of cleaning the rooms, right? The people in charge of cleaning the rooms daily and when the patient leaves had the lowest rates of compliance. But this is the kind of audit and feedback that makes a difference. Most of the time, quality improvement is about giving people the information so they can actually see what's going on. It doesn't require any rocket scientists to come up with magical solutions. It's showing people the data and information that's actionable, that's real time. We made fancy posters, which was kind of fun. And you know, doctors wear gloves all the time when they go in the room with a patient. There's body fluids around. But washing your hands before and after protects everyone. So we plastered these outside of our rooms. We chained these posters around. And this is the data. These are C. diff infection rates, and the lower the better. These are observed or expected rates, which is the standardized infection ratio. So the lower the better. An ODE of 1 means you got the same number of infections as expected. And you can see for the first time, Mayo Clinic Florida is consistently now dropping almost to the top decile in the country for a quaternary academic center, not a small community hospital. And the timing really starts with that hand hygiene around Q4, 2018. So this is, you know, you're going to have to do all of it. You're going to have to do all the other things I listed on the slide. But this is really, really important to get compliance with this, and because this can tip you over when you do all these other things. We're certainly not at this level across the other sites. So this is the same data for our campuses in Arizona and Rochester, and we're trying to spread, right? So spreading this and spreading these interventions, it's not simple, but that's our goal, to spread these best practices. Overall, I mean, if you look at our whole 3 destination medical center campuses, we are making improvements, but we're trying to get all of our sites to below the top 25th percentile, top quartile in the country. This is doable, very hard, but doable. Switching to the last topic I want to touch on is, I think, the importance of culture and values. And some of you may have seen this work, but this is research that I've done myself with colleagues across the country, including at Yale. When you look at something like 30-day mortality rates after a heart attack, and look at the distribution of U.S. hospitals. This is measured and reported by CMS as part of the CMS STAR system. You can see that, you know, the number of hospitals in the histogram are shown on the y-axis, and the 30-day mortality rates after heart attack are shown on the x-axis. And the average mortality in the United States after heart attack still is around 13 to 15%. Average mortality, average chances of death after your initial heart attack. But the range is quite high. You got some hospitals at 10% and some hospitals at 21%. And this is case mix adjusted. It's not because the hospitals on the right-hand side have sicker patients. This is risk adjusted. So this is literally saying, even in a town like Pittsburgh, whether the ambulance takes a right-hand turn or a left-hand turn, unbeknownst to the patient, you can be at a hospital that has a 10% mortality at 30 days or 20% mortality. That's pretty incredible. You know, if I knew it, I would say take the left-hand turn. So now the question that we posed was, what are these hospitals doing differently? Something special going on there? They have better doctors, smarter doctors. They have faster and better ambulances. They have better medications. So we embarked on studying those with what we call positive deviance research, right? What makes Michael Jordan the best basketball player? When there are many people 6'6" and 220 pounds who can jump as high and run as fast. What was different about Michael, right? So using the same approach of qualitative and quantitative research, we looked at them.